Good afternoon, everyone. Thank you for coming to our UCLA Health webinar on palliative care and end-of-life care for patients with brain tumor today. I'm going to give maybe in just another minute as other attendees are still rolling in. So relax a little bit and we'll go over the agenda. I'll start with introducing myself. I'm Dr. Leia Nghiemphu. I am the director of the Neuro-Oncology Clinical Service at UCLA as part of the UCLA Brain Tumor Center and a professor at UCLA in the Department of Neurology. So today we will have a webinar on palliative care and end-of-life care for patients with brain tumor. This is our agenda. First, we will discuss palliative care with my colleague, Dr. Cara Siegel. Then I'll give a short talk about end-of-life care for patients with brain tumor. We'll try and give a short talk between the two of us and try and give a lot of time at the end for you to have any questions and answer. So if you do have any Q&A, there is a Q&A button at the bottom of your screen if you hover over your Zoom screen, and you can enter your questions as we go along there, and then we'll try and answer as many questions as we can at the end of the session. We also value your opinion, so we'll bring the slide up again toward the end. But if you have any opinions about this session or have any thoughts about additional session that you would like to see, please enter our survey. You can use the QR code or use this link here. We'll try and add the link to the Q&A toward the end to see if you can access it there. But otherwise, I would like to welcome Dr. Cara Siegel to start her talk on palliative care. Dr. Siegel is an assistant clinical professor here at UCLA and did her residency in neurology here at UCLA, then went on and did a fellowship on palliative care. And now she is my partner in the caring of patients with brain tumor in the palliative care program in the Department of Medicine, and is also our main neuropalliative care specialist here in the Department of Neurology. So thank you, Dr. Siegel, for giving this webinar.
Thank you so much, Dr. Nghiemphu. I'll go ahead and share my screen. Okay. So, hi everyone. I'm very honored to come and speak with you today about palliative care in neuro-oncology, or palliative care for patients and people living with brain tumors. My name is Cara Siegel, and as Dr. Nghiemphu said, I'm a neurologist and a palliative medicine doctor, which means I provide palliative care specifically for patients living with neurologic disease, many of whom have brain tumors. And I work very closely with Drs. Nghiemphu, Klausi, Lai, and Chong here at UCLA. And I'm excited to share more about how palliative care can support you or your loved one who is navigating serious illness. I have no financial disclosures. So I'll define palliative care today. We'll talk about the common symptoms of brain tumors. We'll discuss medical decision-making and a little bit about medical legal documents. And then I'll share with you some research in early palliative care. So what is palliative care? I thought I'd start by sharing what it is. And palliative care is a specialized form of medicine aimed at improving quality of life. This means helping you live as well as you can for as long as you can. And how do we aim to do that? We focus on a variety of domains, which I'll go into in the upcoming slides. So including symptom management, psychosocial support, spiritual support, centering patient goals and values to assist with medical decision-making, advanced care planning, and transition to hospice when appropriate. Palliative care is also different from many other fields of medicine because it is a very team-based approach. So we work together with nurses, social workers, and palliative chaplains from a variety of denominations to care for patients and their families. And I want to take a moment to show you the difference between palliative care and hospice care. So on this slide, this graph, if you can imagine, has an x-axis of time and a y-axis showing the type of care that someone receives. And this is not specific to just folks dealing with brain tumors. This is really relevant for most disease states, and most of us will develop diseases over time that follow this model. When we initially receive a diagnosis, we're generally all the way over here on the left. And initially, there may be a lot of available life-prolonging treatment. For patients with brain tumors, that of course includes chemotherapy and radiation and surgical resection. And at the same time, we may receive care not aimed just at slowing tumor growth, but also at improving our lives along the way. And that is palliative care. That kind of care can include symptom management, psychosocial management, et cetera, as we discussed previously. And as we progress in time, there may be fewer cancer-directed or life-prolonging options available, and more of the care may be focused on one's comfort. When a person stops receiving life-prolonging care or cancer-directed therapy aimed at slowing tumor growth, either because there are no additional options available or because a person decides they don't want to continue with that and they have a prognosis of 6 months or less, they become eligible for hospice. And Dr. Nghiemphu will discuss hospice later this evening, but I want to make clear that palliative care and hospice are separate services, and one can receive palliative care at any point after the diagnosis of a brain tumor. As I mentioned, symptom management is a large part of palliative care. Some of the common symptoms associated with brain tumors or the treatment of brain tumors include headaches, seizures, nausea and vomiting, vision changes, weight loss or gain, spasticity, immobility, which can lead to pain, diarrhea, constipation, bloating, urinary issues, imbalance, vertigo, weakness, numbness, tingling, delirium, and agitation, cognitive and personality changes. So a visit with a palliative medicine specialist will involve a detailed look at one's symptoms, and palliative medicine physicians address these symptoms with medications, lifestyle management, referral to physical, occupational, speech therapists, dietitians, neuropsychologists, as well as sometimes our integrative medicine colleagues, including acupuncturists. Palliative team members, including the physician, the social worker, and sometimes a palliative chaplain, will also provide psychosocial support for a variety of the emotional symptoms that are very common with brain tumors. So these are extremely common and at times don't get enough attention or care. These can include isolation. So many of my patients share with me that they can feel alone in their journey, loss of identity, and folks may have so much identity shaped by what they do for work and may no longer be able to work. They may have identity loss around no longer doing athletic pursuits or providing for their families. Just a variety of ways that that can happen. Loss of autonomy. They may rely on others now in ways they never had to before. And all of this can lead to anxiety and depression. They may worry about the well-being of loved ones, particularly for patients who have young children or who are caring for others who are sick. They may worry about death or worry about suffering at the end of life, worry about practical or financial matters, have existential or spiritual distress, a loss of faith or anger with God. And a whole separate and very important issue is also that of caregiver burden. In palliative medicine, we think of the family as a unit, and we can do one-on-one appointments just with the caregiver as well to provide additional support. This is all to say, if you or your loved one is having these emotional experiences while navigating brain cancer, you're not alone, and working with a palliative team can be very helpful support for this. Palliative care also helps with medical decision-making. When I first meet with patients, I usually ask them, tell me about you outside of your illness. Who are you? And understanding who they are and what is most important to them really helps me guide them through medical decision-making and personalize their medical care. For instance, it's not uncommon that for patients who may be nearing the end of life, their priorities may be to maximize their time with family and to avoid suffering. And sometimes additional chemotherapies may result in more time in the hospital, more side effects, and only minimal life extension. In those cases, the palliative team can help the family navigate when it may be a good time to discontinue cancer-directed therapy alongside your neuro-oncologist. On the contrary, there are patients for whom life prolongation in almost any state is very important, and we can help advocate for that. We also help people with advanced care planning. This includes completion of advanced healthcare directives, which is a document really stating your preferences for what kind of medical intervention you might want or not want, and what outcome you're hoping to achieve with that intervention. I'll review the UCLA Advanced Healthcare Directive on the next slide. We also help with determining and designating a health surrogate or healthcare direct power of attorney, which is someone that will make healthcare decisions on behalf of a patient if the patient can no longer do so for themselves. We also help with completion of POLST forms. This is a form which states what kind of healthcare someone would want in an emergency and is actually a physician order. This can be shown to emergency medical personnel or healthcare workers at a hospital and will be honored. It's very important, for instance, if someone has, for example, decided they wouldn't want to undergo CPR, but instead would want to have a peaceful passing if their heart were to stop. If emergency personnel are caring for them for another issue, like say they develop appendicitis, but they end up in an emergency situation where their heart stops, the emergency personnel will honor the POLST form and not perform CPR on that person. Advanced care planning enables you to work with your healthcare team so they understand your perspectives and can integrate them into future treatment recommendations. So as mentioned before, we work with patients to help them think about their values and preferences to guide the medical care they receive. And this is an opportunity to think about what future health states one desires. For example, being able to carry out certain activities and what situations one would want to avoid. For example, being kept alive on machines while in a coma. The advanced directive is a place to record those wishes so they can be carried out by the healthcare team. And you can indicate your healthcare agent on this form as well. That would be a health surrogate or a healthcare direct power of attorney. We also help with transitions to hospice when appropriate. And we work closely with the patient, the family, the whole palliative care team, and the neuro-oncology team to understand when that is the right choice for a patient. We provide referrals to hospice agencies with direct experience with caring for patients with brain tumors. And while hospice then assumes primary care of the patient, we remain available to patients and families for questions and additional support. This is quite important because Los Angeles has an issue where we've got a low bar to become a hospice. And as a result, we have hundreds of different agencies with a really wide variety of quality. So we really try and provide patients referrals to agencies who are experienced and who we know take fantastic care of our patients and families. With our remaining time here, I'd like to share with you some of the research that's been done on studying the need for and the effects of palliative care. This is a very famous study in palliative care, one of our landmark trials that I'd like to share with you. And this is a study by Dr. Temmel, published in New England Journal of Medicine in 2010. She looked at the effect of early palliative care on quality of life, the kind of care people receive at the end of life, and on their survival in patients with stage 4 lung cancer. This was an important question because prior to this, palliative care had really only been involved in patients' cares really at the end of life. So she wanted to know what would happen if soon after the diagnosis, patients had the supportive palliative care. So she had 150 people in her study with metastatic non-small cell lung cancer, stage 4 lung cancer, who'd been diagnosed within 8 weeks, and all were doing fairly well. They had a high functional status. And she wanted to see this effect of involving palliative care earlier on in this folks. So half of the 150 patients received early palliative care, which meant monthly meetings with a palliative provider starting just about 8 weeks after diagnosis. And the other half received standard of care, which included referral to palliative care whenever generally requested by the patient, the family, or the oncologist. And at that time, it was typically fairly late. The researchers found that compared to no involvement of palliative care, patients who received early palliative care had better quality of life. The quality of life scores are up here in this first section, and they're all higher than if they received the standard care. But what was really striking was they looked at 2 different scales for quality of life, both at the beginning and at the end of the 12 weeks. And in the standard of care model, they found that over 12 weeks, as people's cancer was progressing, their quality of life got worse. This wasn't particularly surprising because folks were getting sicker. And so these negative numbers here in the standard care model show that as time is progressing over 12 weeks, people's quality of life diminished. But in the group receiving palliative care, not only did their quality of life not get worse, it actually got better by several points on this scale. So although they were 12 weeks further into their disease, which was progressing, they were reporting a higher quality of life than they had previously. What was also a very surprising finding is that involvement of early palliative care actually had a benefit on survival. Folks receiving standard of care lived for about 8.9 months, and folks receiving early palliative care lived 11.6 months. Dr. Temmel also looked at what type of care people received at the end of life and whether this was different in the group who received early palliative care. She found those receiving early palliative care tended to be more likely to enroll in hospice. They were in hospice care for longer, and they were not receiving chemotherapy in the last 2 weeks of life. They also had completed documents stating their medical preferences more often than those that did not see palliative care early. So compared to standard oncology care, integrated palliative care led to an improvement in quality of life, which they assume may be due to improved symptom management. It led to lower rates of depression, which may be again due to improved symptom management, treated depression, and maybe more illness acceptance. Less aggressive care at end of life, which may mean that in their final weeks and months, they were not in the hospital and able to enjoy that time more fully with family. Greater documentation of resuscitation preferences, and higher survival rates. They hypothesized that the higher survival rates may have been due to earlier recognition and management of medical issues if patients had more time to talk about the symptoms they were experiencing, potentially improved quality of life and mood, less chemotherapy at the very end of life, and longer hospice admissions. And we find that in some cases, hospice confers a survival benefit because some people get such good care on hospice that they actually do better and live longer. So these findings have been replicated in a variety of other cancers, but not yet looked at in brain tumors. In Germany, this trial was just opened a couple of years ago, and so we'll have those results to see if in patients with brain tumors there are similar findings. So as I stated at the start, the goal of palliative care is to help people live as well as they can for as long as they can. And I hope this dispelled some preconceived notions of what palliative care is or isn't and was helpful. And I look forward to your questions and learning how I can support you. Okay, we will take a 5-minute break. So we'll be back at 4:27 and then hear from Dr. Nghiemphu.
Hello, everyone. So I am back. I hope everybody did get a little time to stretch. It's always important to have some movement throughout your day. I will start on my talk on the end-of-life care for brain tumor patients. Most of my talk will focus on the symptoms that we may see in our brain cancer patients, changes that occur throughout their disease, and also talk a little bit about what lead to the causes of death of brain tumor patients. I'll touch a little bit more on hospice care as well as end-of-life decision making. I think this is a little bit take on what Dr. Siegel said earlier. So why do we want to talk about end-of-life care? As a neuro-oncologist, I always hope to give excellent life prolonging therapy that will lead to normal lifespan for all of my brain tumor patients. However, I know that these therapy can be toxic and patients would need palliative care as early as possible. And unfortunately, many of the brain tumors are not curative, and patients will need more and more palliative care as they go and eventually needs hospice and may see the end of their life earlier than we would like to see. It is very hard to talk about end of life. I think whether it's related to someone who has brain tumor or it's just related to our own lives, it's always scary to talk about death. There's a lot of fears and also a lot of social and suffering thoughts that enter all of our minds when it comes to thinking about death, whether it's a patient or of our own considerations for one's physical self, social, financial needs, the family, spiritual needs, as well as just fear about what will happen toward the end. I think the only way we can really reduce this fear and this pain is really having as much knowledge as possible. So really that's the goal of this talk, just to give you the knowledge and communication of what may happen toward the end of life. I think it's important for me to really start out by saying that in general, for most brain tumor patients, unlike a lot of different type of cancers, death from brain tumors are usually very peaceful, painless, can be managed to give patients as much comfort as possible, and is usually in an environment that's comfortable for the patient and the family. I'll talk a little bit about the symptoms at the end of life. Really, a lot of time, the first question I get from patients is what caused death and what caused the symptoms. And it's about the brain when it comes to a brain tumor. For all the symptoms, it's really related to the tumor location. I always say the brain is like real estate. It's all about location, location, location. Wherever the tumor may be, that's usually the first symptoms that it causes. And then it's the symptoms caused by the swelling and pressure from the tumor onto the rest of the brain that then leads to other symptoms. And there are changes that we usually expect in someone who has brain tumors, especially toward the end of life. Realize that some of these symptoms may be seen early on in the diagnosis of having a brain tumor. It doesn't mean that just because they have these symptoms, it means that they're toward the end of life. It's just these are the progression of symptoms that we do see. So sometimes some of these symptoms may be there for months or years, and then other symptoms may occur just toward the very, very end of life for just a few days or weeks. But usually patients would start having weakness and fatigue, some decreased cognition. They become less and less mobile, may become wheelchair and then bedbound, have less in food and drink. And usually at about this stage is when I would say is closer to the end of life. They may become very sleepy and drowsy, usually go into a comatose state. And I always say most brain tumor patients look very comfortable toward the end because they may just fall asleep into a coma and eventually end their life quietly. But usually with weakness and fatigue, a lot of these symptoms, again, occur based on the location of the tumor. But most of these symptoms may be there for a long time while someone has a brain tumor, but they usually become more progressively fast changing toward the end of life. Patients may have to decrease ability to move. They will then start needing more and more care. They become less independent of activities of daily living. They may have a lot of falls. They can become wheelchair bound where they can no longer walk on their own and then may eventually become bed bound. I think during that time, things that need to be considered are using adaptive devices. Maybe someone may progress from using a cane to a walker, then wheelchair. If they're still mobile, it's important to have fall precautions. Make sure there's railing inside the house, remove rugs, etc. And this is where the help of our palliative care team and also our home health teams are very important for our patients too. If the patients become bedbound, it's very important to think about using frequent turning, lots of movement and massages. A lot of that because we want to reduce the risk of pressure ulcers on the skin. And also it helps reduce joint position fatigue if the patients have good range of motion. Usually here we may recommend using hospital bed or lift devices. Toward the end of life, there can be a lot of issues with toileting. Partially it could be because the patient has a lack of mobility to get to the toilet in time, but brain tumor can also lead to incontinence because the brain in the end is a main organ that controls our ability to know when to urinate or to have a bowel movement. It's important to remember that we want to give our patients as much dignity as possible during these times. So some of the things that can be done would be having bedside commodes, a urinal, so it's easier for the patient to get to the toilet. Use bathroom regularly to avoid accidents, especially if they are still trying to get out of the house, try to enjoy their daily life. If they become diaper dependent, make sure that there's good skin care. This is the movement, the turning that I mentioned earlier, as well as keeping the skin dry, using catheters or absorbent pads to help with skin care during this time. And another symptom that how patients experience quite often toward the end of life is just a lot of decreased cognition. This is when they can become very sleepy, a lot less communicative. They don't have as good short-term memory, forgetful, can become disoriented. A lot of this comes from having tumor that's causing pressure on the brain, and it causes pressure on parts of the brain that helps us control our daily life and emotions. So patients may start having a lot of behavioral changes. It can be very combative because they're disoriented, not knowing what's going on. They're losing control, losing their independence. Patients can become very dangerous or impulsive, have falls, or they may just be drowsy and sleeping all the time. I think during this time, I always remind everyone that the behavioral changes is no longer the patient, right? It's really the tumor that is causing this. And the most important thing to do is try and provide them a calm and safe environment. Again, provide a lot of fall precautions. It's okay to still touch and talk to patients even when they're sleeping or very drowsy. It's important to have communications that's in a very, very calm manner. They may need a lot of redirections, and that's okay to do. They may need guidance or to initiate activities of daily living. A lot of time patients may not know that it's time to eat or time to sleep or time to shower. It's also important to give these directions in very simple ways and commands and be as flexible as possible. And again, I think it is about the disorientation and the short-term memory that patients are having at this time. So it's okay to, not be complicated about things, and things routines no longer need to be as they used to be. We can also use a lot of medications for anxiety and psychosis during this time. A lot of patients also ask me about the use of steroids, especially toward the end of life. And I know a lot of brain tumor patients are on steroids periodically throughout their time of having a brain tumor. Toward the end of life, steroids are really not going to help prolong life, but they can help reduce some of the brain swelling and edema. So maybe they can help reduce some of the symptoms I mentioned earlier. They can improve mobility and fatigue and drowsiness. They can also partially improve some of the neurological deficits. If the tumor is not in the area, but really just causing swelling, it can provide some temporary relief. But realize that there can be a lot of complications with steroids, especially at the use of higher dosages. So as there's more and more swelling on the brain as a brain tumor grows, the dosages of steroids previously used will no longer be effective. But there is a point where, how high can we go without causing complications? Steroids can come with a lot of complications. Some of the complications are more with long-term use, things like myopathy or diabetes, or changes in body habits, for instance. And perhaps at the end of life, those things don't matter as much. However, I think a lot of the other complication of steroids can impact patients' quality of life. It can cause a lot of psychosis, hallucinations, cause anxiety and behavioral changes, insomnia, decrease immune system, so increases risk of infections. And so I think for patients at the end of life, even though we try to use some steroids to see how much symptoms we can relieve, we probably don't want to keep going up on the dosing either, to try and limit the bad side effects as much as possible. Other complications that we see more often during end of life are these: seizures, pulmonary embolism, infections, and also dehydration. Realize that brain tumor patients at any time during their journey can have these complications, but usually they're easier to manage while we're keeping tumor stable. When the tumor becomes more progressive, it is harder to manage these types of complications, and patients may actually pass away because of one of these complications instead of the tumor in itself. We know that brain tumors can cause seizures. A lot of patients with brain tumors are on seizure medications, having seizures, but like I said, we can see a lot more seizures toward the end of life. And when the seizures are not controllable or become repetitive, it definitely can limit their quality of life toward the end, because they're no longer aware to enjoy life if they're having seizures all the time. And multiple seizures can lead to end of life by itself. So oftentimes we do want to continue seizure medications, because I think that does help quality of life. Usually most seizure medications are oral medications, but patients can lose swallowing ability, and I'll talk about that a little bit later. So we may want to switch medications to liquids and suppositories, use barbiturates in suppository form, or concentrated benzodiazepines, for instance. Patients also get an increase for pulmonary embolism. What they are actually clots or embolus in the blood vessels in the lungs. And when there are clots in the blood vessels, this actually causes a lot of breathing difficulty, and oftentimes a lot of chest pain and shortness of breath, and a lot of anxiety and distress because of that. there is a much higher risk of having a pulmonary embolism when somebody has cancer in general. And especially for brain tumor patients, the risk becomes even higher than just general cancer patients because they're no longer moving around as much. And so their veins can develop clots more easily because they're not moving their arms and legs. Almost half of the patients with brain tumor patients, half of brain tumor patients actually can develop a clot during their lifetime. And it can happen anytime when someone has a cancer, but like I said, it is more during the end of life. And if the less mobile patient, someone who is staying in bed and staying bedbound longer, it is quite eventual that they may have pulmonary embolism. And this can also be very uncomfortable. So, we want to recognize this and try and prevent this by moving the arms and legs and massages, for instance, but also with the knowledge that if we are prolonging someone's life, this may become an eventual issue beyond the brain tumor in itself that can cause death. Another complication that we see very often with brain tumor patients, and also maybe a reason that patient may pass away from infections instead of just their brain tumor in itself. The most common infection in brain tumor patients are actually aspiration pneumonia. What that means is that you can see here the sideway picture of the esophagus and the breathing tube, the trachea. They're actually right next to each other. So when someone eats and have food stuck or cannot swallow it well, instead of going down the esophagus into the stomach, it may go into the trachea, into the lungs instead. And when food gets stuck in the lung, in somebody who is very weak and bedbound, they will have a hard time choking on it and try and get rid of that food product. That can cause them a lot of breathing difficulty, chest pain, shortness of breath, fever, coughs, and then cause a pneumonia because our lungs just don't want to have anything foreign in it. And that actually can be very difficult to treat. Patients at end of life already have poor immune systems. They've been on chemotherapy, they've been on steroids, so their immune system is already not great. Like I mentioned, because they're already bedbound, they'll have poor ability to cough up the secretions to try and clear the lung of the infection. So even if we use a lot of antibiotics, or very strong antibiotics, sometimes we have a hard time treating aspiration pneumonia in patients towards the end of life. So again, patients may actually pass away when they have these type of infections. Instead, if they have very poor function toward the end of life, they can get other infections too, like skin infections. What I mentioned earlier, it's important to have good skin care. Also, urinary tract infection is also another very common one. Again, it is very difficult to treat any of these infections when patients are toward the end of life. Really, probably I would say the more common cause of patients passing away from their brain tumor, other than the other ones I've mentioned before, is probably because over time with their brain tumor, they start having less and less food and fluid intake. From a brain tumor in itself and from the treatments that patients have, that may cause a decrease in appetite and for food already. And sometimes toward the end of life, our organs are not working so well. The stomach is not digesting food as well. So patients may actually no longer want to eat as a protective mechanism. Also protective mechanism from aspiration pneumonia, for instance. I have heard from caregivers that patients often would, clench teeth and express their desire not to eat, almost like, that's their way of being able to control their situation. They can also start getting mechanical problems with swallowing. They have poor muscle function because the area of the brain that control those muscles now have tumor or swelling on the brain. Usually with something like dysphagia, which is the medical term for having trouble with swallowing, they usually actually have difficulty with clear liquids first. So usually a hard time drinking water or juice or coffee instead of the thick food. They may also have a lot of cognitive problems. They lose ability to know how to eat, or even lose ability to know what is hunger. They can be sleeping all the time, so they're no longer sleeping. They're really just too sleepy to eat or drink. There are some things that can be done while patients can still have some food or fluid intake. Like I mentioned, it's important to watch for aspiration so that the food doesn't go down the wrong pipe. Keep the head of the bed elevated. When patients is up and enough to be eating, they should be sitting upright to eat and drink and not be laying down in bed during this time. It's important to change the diet. This is when we may get feed swallow evaluations on patients so that they can recommend whether patients can have chopped or puree diet. They should have multiple small meals throughout the day because they may just be awake enough to have just a small portion of food instead of a lot of food at once. There is a over-the-counter product, comes in many different forms. This is really a powder. It's usually called thicken it of some sort, like thicken powder, thicken it. There's different names to it. And depending on the amount of powder that we can add to the thin liquid, it can make it into like a nectar or a smoothie or even thicker soup consistency. Because like I mentioned earlier, the swallowing problem is usually with swallowing thin liquids first. So a thickened liquid will make it easier for patients to swallow. That's usually we discuss with the patient about changing the type of medication they can take so that it's easier for them to take also. It's important to give them mouth care at this time because they're not swallowing a lot of things, maybe suction tube for saliva, ice chips, or swabs, which is some moist swab for the mouth for some mouth care. And I think it's very common that patients ask about or caregivers ask about artificial nutrition and hydration. Because obviously when somebody is not eating or drinking what they normally need to sustain life, we should think about whether artificial nutrition is important or not. So I thought I'd spend a slide explaining what all of that means. One is hydration can be given by just the IV, like through an IV bag. I think it's important to know that when fluid or food is given through the IV, it's mostly fluid that's given, even with something called TPN, which is nutrition through a tube. It cannot have the same substance that we would get with solid food. And so it usually causes a lot of fluid overload, can cause a lot of bloating. Obviously, having to put an IV in all the time can cause a lot of local pain to a patient. And all the extra fluid, because there's not enough food substance in the fluid that's given, can actually go into the interstitial, the body system, parts of the lungs, for instance, and cause a lot of difficulty breathing, congestive heart failure, bloating, coughing. So being on artificial hydration alone for a long time is actually not very sustainable without causing a lot of discomfort for patients. So usually if they want artificial nutrition or hydration, they would need to be placed through, either a tube that goes to the nose, down to the esophagus, down to the stomach, that's the nasogastric tube, or have a minor surgical procedure that put a feeding tube straight into the stomach. In the long run, we have known from studies of brain tumor patients and other cancer patients also that when patients are toward the end of life from cancer, having artificial nutrition actually does not prolong life and survival, and oftentimes can lead to, like I said, all of these other complications and pain and bloating. sometimes having food directly into the stomach while their organs is not working so well, patient actually would not be able to even absorb the feeding through the stomach because the stomach lining is actually no longer digesting the food as well. So this is, I think, one of the decisions that, like Dr. Siegel mentioned earlier with the advanced directive, should be discussed early on, if possible, if patients would want to have artificial nutrition and hydration. Again, it doesn't necessarily give them any quality, right? Because they're not actually enjoying any eating of food. It kind of bypasses the enjoyment center of eating, for instance, and it's purely just giving nutrition. And we also, like I said, know from studies that having artificial nutrition actually does not help prolong life. What it does, though, is that it can interfere with one other way that patients with brain tumors can pass away from. And oftentimes, this is really the reason why patients pass away, and that's dehydration. When patients are very, very sleepy and not really taking in food or hydration or food or water or drinks, their body actually goes into a dehydration state first. If we go through hunger strikes, for instance, people can actually live for a very, very long time without food, weeks, months, actually. But people cannot go for very long without water because what happens is the body actually will shut down. When water goes into our system, it actually helps clear out toxins that the body normally makes, especially in the brain. So when someone is not taking in the water, all of that toxins actually get built up into the brain. And what that does is actually put the patient into a deeper comatose state. And so they actually are less restless, don't really actually have any sensation of dehydration or thirst or hunger at that point. And it actually helps the brain shut down sooner just from the toxin buildup from dehydration than, say, actually waiting for some of the other processes to take over, like having a pulmonary embolism or infection, or the tumor invades to area of the brain that would then shut down the rest of the body. Purely, honestly, just from the dehydration process alone. And I think it's important to understand that dehydration is actually a very natural process of death. And it really does not occur until there's no longer any substantial amount of nutrition or hydration that's given. So for patients, if they undergo artificial nutrition with some of the other methods I mentioned earlier, it actually stopped them from having this natural process of death. And then we would then wait for the other processes of death, like seizures or pulmonary embolism or infections, or large enough tumor growth before the patient would lead to death. So there's actually a very, very natural process. Most patients just go into a coma and eventually have stopping of their brain functions. They really don't have any anxiety during this time, no thirst, no hunger or pain. And this is probably the only process where we as physicians can really predict how long before someone would pass away. Usually it's about 3 to 7 days once they kind of go into this comatose state and no longer have any nutrition or hydration, that they would pass away. It's actually otherwise very, very unpredictable how long this whole death process takes. I think a lot of time patients will ask me, how much longer do you think somebody will survive? And honestly, most of our predictions are usually wrong and is completely use just averages. Like we know in general, this is how long a patient can last. But, sometimes even when the patient has not reached the dehydration process. They may still have something else happen that they may pass away within a couple of days, versus other patients may linger on for months before the dehydration process starts. But usually when a patient stops eating and drinking altogether and kind of go into a deep coma, it's usually within 3 to 7 days. So that's really the only time that can be predictable. I've always found that somehow, even when the patient doesn't seem to have any cognitive awareness, they still seem to know death expectations somehow. Like they somehow know if there's an important event, for instance, if they've been waiting for a wedding or a family event, and they actually can rally and actually stay alive long enough to pass after the event. A lot of time family member and caregivers are afraid that there is death that's happening because a patient took a medication, for instance. And I would say again that there's no cause and effect to that. It's completely unpredictable. It's really just a coincidence, and it's not because they took a medication that leads to the death. Sometimes I have also had caregivers that tell me that they spend hours with the patient because the dehydration process started and they think that the patient would go soon, and then they walk away for a few minutes to have to go get grocery or something, and that's when the patient passes away. I think a lot of people spiritually think that some patients actually want to have space to let go and don't want to die in front of their loved one or family members. So I think it's always important to realize that we cannot predict the exact minute of death, and it's okay to spend as much time as one can with their loved one toward the end, but it doesn't mean that you are missing out if you're not there at the very last second. I think the one other thing that I want to bring up toward about end of life symptoms is there are a lot of changes in breathing. Like I mentioned before, right? There's already trouble with swallowing, so sometimes the saliva gets stuck in the throat, and so a lot of caregivers will notice rattling breath sounds because of increased secretions in the mouth. They also notice something called change stroke respiration, where they may have very irregular respirations throughout the time. Sometimes they may have a pause, an apnea, a pause in breathing, and that's when caregiver think, oh, the patient passed away, and then they started breathing again. These are actually all very, very normal. The patient is not having discomfort during this time. It's actually all related to reflex of breathing due to an area of the brain called the brainstem. So it's not causing them a lot of distress. I think hospice is very good at helping with this and to try and breathe, even out the breathing. And honestly, most of the time that's really for the caregiver and the family rather than the patient. But just realize that can be very normal toward the end of life. I think that's I know Dr. Siegel talked a little bit about hospice, but I think this is a good time to talk a little bit about when to choose hospice and what it's about. We help hospice and we help with the decision of when to enter hospice, but I think in the end it should be an individual choice of the patient and the family. Usually patients or family choose for the patient to enter hospice when we no longer have any more treatment options, when they think there's no more quality of life. There's no treatments that will increase survival. They know that treatment is not going to improve the patient any longer, or treatments are causing too much side effects. And I think it's really a balance, right? A balance between whether treatments are still giving any benefits versus treatments causing too much side effects. And when the scale is tipped in that balance, perhaps this is time to enter hospice. However, it's okay to talk about when to enter hospice very early on. I think this is where we work with our palliative care specialists, and it is important for us to actually send our patients to palliative care, like specialists like Dr. Siegel early, so that patients have the autonomy to talk about what's important to them, whether they would want artificial nutrition or hydration early on when they're still able to tell us, the physician, and their family members what they want, and not wait toward the end for this decision of when would someone go into hospice. Just talk a little bit so that caregivers understand that hospice care in the state of California is usually routine home hospice care. That's usually mean that patients have the hospice care at home in a comfortable environment. It can also be done in a nursing home or group home, or even in a hospital. However, in the state of California, there's not an actual standing building called a hospice. Hospice is more of a service rather than a building. And usually when patients, what happens is the hospice services would provide regular scheduled visits for the patient, as well as social and emotional visits, usually by nurses. It may be once a week, a couple times a week, depending on how much needs the patient have, to make sure that they have good quality of life and good symptomatic management during hospice. But it's, like I said, not usually does depend on the family to provide the day-of-day care for patients while they're in hospice. Sometimes the patient can be in a facility. Is usually like a hospice service may have a couple bed within a hospital, and that's usually only for high level of hospice care. Like a patient may have a lot of pain and they need to control the pain over several days, so they would admit the patient for a few days. But usually after things are under control, the patient would then return home or to a nursing home. Some hospices may have respite care, where they may be able to admit a patient for a few days to give caregivers a break. But like I said, hospice care is usually not continuous or round the clock until really toward the very end of life, or when there's a medical crisis. If the crisis resolved and the patient is still alive, the routine care would just resume at that point. Lastly, I want to talk a little bit about the End of Life Option Act. I think I've often been asked about this question quite a bit. And what the EOLOA is actually a law in California since 2016, that California residents can ask their physicians to prescribe aid in dying drugs. It's not the same thing as assisted suicide. There is no physician that's assisting the patient to die. All the physician can do is prescribe medications that would lead to death. But the patient must be able to take this medication and choose their own time of when they would take it. So the physician is not assisting during that time. Patients have to be a resident of California and 18 years or older, have a terminal illness that we, the physician, decided that can certify that they have less than 6 months of life expectancy. And the important thing, especially for brain tumor patients, to know is that the patient has to be the one that's requesting us for these prescriptions. They have to have the capacity to make the medical decision and not have any impaired judgment due to a mental disorder or neurological disorder. They also have to be physically able to take and ingest a drug themselves. So it's important to know, because a lot of brain tumor patients have decreased cognition as tumor progress and toward the end of life. So if they no longer have the capacity to ask us for these prescriptions, then we would not be able to go through with the End of Life Option Act. And also briefly, just over the process, this is something that we work together with our palliative care colleagues also, because usually the patient needs to ask one of us with 2 verbal requests. So again, it's important the patient can also verbally ask for the prescriptions. The verbal request must be at least 48 hours apart. They also need to see a counselor and a second consulting physician here at UCLA. So a lot of time that's, a neuro-oncologist and a palliative care physician can act as those 2 physicians. They also have to provide a written request with witnesses signing it, and the witnesses cannot all be family members. And then what happens is then one of the physicians would then prescribe the aid in dying drugs that they can pick up from the Ronald Reagan UCLA pharmacy. And again, it's very important to understand that the requests have to be verbally and requested, and have to be a written one, has to be requested, so a patient has to have the ability to do both of those. So just, I think really at this point, that's kind of the end of my talk, because I want to open it up to have more to answer a lot of your Q&A that you're asking right now. Here's a QR code or the link, and I think we'll email this also to you at the end, so that you can put in a survey and let us know of other things that you may want in future webinars from us. So we'll go on to the Q&A at this point. So if you have any questions, do put it in the Q&A button, because I think we'll go to the top, right? So I'll start with the first question, which is, why are neuro-oncologists required to add palliative care specialists at diagnosis and as a standard of care? And I would let you know that I think it should be standard of care. We never, I guess, require anybody to do anything, but I do think that it's a very important process of care for our patients with brain tumors. It is harder, though, for us as neuro-oncologists. The very first time we meet our patient, we're so busy talking about, let's plan this, let's plan that, let's do the scan here, radiation, chemotherapy. So we may forget the very first time, but I think we should try as much as we can to get our patient to palliative care, because I think that gives the patient a very whole and holistic care for their brain tumor journey. And together, I think we work very well for our patients.
Great.
Let Dr. Siegel goes next.
Sure. I'm answering Chelsea Brooks's question. At what point in the diagnosis and treatment process do you find a palliative care referral optimal? I really think that working with someone kind of soon after diagnosis is the most helpful. Dr. Nghiemphu talked about all of the changes that someone goes through as they get more advanced in their disease. And so it's so much better to be able to support them earlier on, to understand what's most important to them and have all of those preferences documented. And then there's a huge amount for most people of distress and worry kind of at the initial time of diagnosis. So I think that's a really important time to give extra support as well. And Dr. Nghiemphu, I started clicking that I can answer a lot of these, but if there's other things you want to add, please do.
Yeah, I think we can, I do want to bring up, I know I went through, because I saw the question on the artificial hydration and nutrition as I go through. I do want to say again, I think, I already explained why oftentimes, and what I did not say is probably 95% of our patients actually choose not to have artificial nutrition or hydration at the end. But if they do, we usually do that before they go into hospice, because this required usually a minor surgical procedure. So we try and do that beforwards. And then while they're on hospice, if they have a feeding tube, that can be managed by hospice. It's something that can be done.
And you asked here, Patty asked about patients who use end-of-life options when admitted to hospice. And another person also asked about you have to be admitted to hospice. You do not have to be on hospice to obtain or to use end of life option act medications. We strongly encourage that people do enroll in hospice prior to ingesting that, because hospice gives a lot of support to the family. But it's not a part of the law. And it's patients commonly obtain the medicine before going on to hospice.
I think it's also important to remember that if someone passes away without hospice care, there's a whole different procedure at the end of death. You're supposed to call police and things like that. And it's become more complicated, honestly, than necessary for patients who is passing away from the brain tumor, right? Even though they took the medications, the anodyne drugs, the real cause for that is really the brain tumor. And so on our end, we can certainly certify that they pass away from brain cancer instead. So they can bypass the complicated issue, calling police and things like that if they are in hospice, because that process alone, make things simpler for that family. So I think that's why we always recommend it. What do we do with patients who have longer than 6 months of life yet know that they may have cognitive loss? Honestly, that's, I think, a huge question that us as neurologists struggle with all the time. Unfortunately, that is the law. So I think it's a little bit easier with brain cancer patients rather than other neurological diseases, because as long as we can say on average patient at a certain stage in their disease have 6 months to live. Again, like I mentioned before, life expectancy is completely unpredictable. So we're just saying on average they have 6 months to live. They can be a lot longer, can be a lot shorter. But as long as we can at least say that much, then they can ask. And actually, it used to be 2 weeks between the two verbal requests, but now the law changed like last year to say that it's actually only need to be 48 hours apart. So the process at UCLA, I mean, we're pretty fast. We can usually get it done within 3 weeks, I think, right? Especially a lot of patients may see me and Dr. Siegel, and with our social worker, we're like totally aligned, and we can do it pretty fast these days. But yeah, I think it's a struggle, and unfortunately, we can only do what the law dictates when it comes to that 6 months.
There is active litigation ongoing now for patients with a variety of neurologic diseases that want more access to end-of-life option medications. And the medication was not really designed with neurology patients in mind. And so there are a lot of issues with access if someone has, lost their cognitive capacity to make that request, for instance, but it's known that that's what they would have wanted, or they don't have the physical capability to ingest anymore. So these laws may be shifting in the coming years.
You know anything about donation of organs, Dr. Siegel? I know a little bit, but I don't know if you know.
Not much. Yeah.
Okay. Usually I would say the donation of organs is depending on how the patient would like to do that. A lot of the time with cancers, some of the bigger organs are actually not accepted because the patients have cancer and they worry that there's cancer seeding outside of the brain, even though we know that's a very rare condition. Is still not clear that other organs would be accepted, but things like skin or cornea are accepted. I think there's actually at UCLA, so it's really dependent on the system. At UCLA, there's actually a organ donation service. It's called the Decedent Affairs, actually. So if you are one of our patients at neuro-oncology, just ask one of the physicians. We can give you the phone number to the Decedent Affairs, and you can set it up ahead of time, actually, when it comes to donating organs, or if a patient wants to donate their brain for research with us, we would also go through them too, and we have a process set up for that. Would you take the question from Christine Jepson?
Yeah, so I see patients all over the state of California and then some out of state as well. But I also work, there are palliative care providers kind of across the country.
So yeah, usually there are also, some of the patients who are far away from us. I think some home health also have palliative care dedicated. I think the little difference with Dr. Siegel is your neuropalliative care with neurology and training. And so I think for brain tumor patients, with a lot of the symptom management for brain tumors is a little different than just cancer or end-of-life care patients in general. But I think it's a growing field also.
Yeah.
There's a lot more physicians going into the field. So
Yeah.
I think locally you may be able to find palliative care physicians.
And I do see a majority of my patients virtually. So that's also an option.
Just to answer Michael Siebert's, we are recording this, so it should be available. I'll let you know, Michael, or Lou will, when we have it available online. And thank you to Anonymous. It's very nice to hear that you agree with what we're saying. For Shauna Rickard, you're asking about when patients should stop Optune. I assume more toward end-of-life care. And I would say definitely, I guess one thing I did not talk about with hospice is that you can only enter hospice if you have chosen to stop all treatments, all active treatments. So definitely Optune is considered an active treatment. It's a device is being paid for on a monthly basis by either your insurance or your Medicare. So if somebody is going into hospice, they would no longer be able to have that provided to them. So before hospice care, they definitely would have to stop Optune. Beyond that, we usually recommend stopping it when patients have tumor progression, because we don't think continuing it is necessarily going to help, or when it interferes with quality of life, because it's something patients have to wear all the time, and toward the end of life, even before they stop active treatments, they can be very disoriented and combative and having something stuck on their head all the time. A lot of patients don't tolerate that.
And Anonymous asked if someone passes on hospice, what does the carer do? You do not need to call 911. Hospice will come. When someone signs on to hospice, you have a phone number to reach a physician and an RN any hour. So for any type of symptom management issue, for any emergency at all, including your loved one passing, and hospice will come to take care of things and take care of the body and provide support, all of that. And this segues nicely into Cindy's question about, is someone with the patient 24 hours a day? And they are not. So Dr. Nghiemphu mentioned that family members still provide that day-to-day caregiving. So whether through hired caregiver support, which is paid out of pocket, or from family support. And hospice comes in typically a few times a week, and it often is the same people. So it's good to, meet some of the people ahead of time when you're interviewing hospice, and ensure that you kind of like the people that you'd be working with. But when someone is at the end stages of life, if they're having a lot of uncomfortable symptoms, which, as Dr. Nghiemphu also mentioned, is not typical in brain tumors, and most people with brain tumors have a very peaceful passing. But if they're having a lot of symptoms, pain, nausea, anxiety, distress, hospice can be there 24/7 for that time to manage those symptoms if they're hard to control.
And yeah, and we do try and keep a list of hospices that we work with. Just realize that, UCLA in itself, we don't have a hospice service attached. Some healthcare systems do, we don't at UCLA. So when we place referrals to different hospices, it's really because we've had some experience with them. We have their direct contact information. We know who their representatives are. But we're always, I think, willing to take feedback. I've changed patients, even while they're on hospice, if something happened and the patients and the caregivers are unhappy with this hospice service, I've changed and refer them to other hospice services. So I think it's always important to also keep us in the loop if you're a caregiver with a patient on hospice, so that we know. And like Dr. Siegel mentioned earlier, both her team and our team in neuro-oncology, we still are available even while patients are on hospice, and we want to know if it's working out with the hospice services or not.
And David asked, what's considered treatment for hospice purposes? So typically hospice focuses entirely on comfort-oriented care. So no, in general, life-prolonging care. So that would mean no cancer-directed therapies like chemotherapy, radiation, those kinds of things. But there are some gray areas. For instance, if someone gets a pneumonia, taking antibiotics may prolong their life, but it also might make them feel more comfortable. So they typically will provide antibiotics if the person wants, because that can make them feel better, or for a UTI, et cetera. But they wouldn't do things like IV antibiotics or really intensive interventions. And sometimes someone might go on to hospice and then have something totally unrelated happen. I had a patient, for instance, who had an anaphylactic reaction to something. And so the hospice said, go to the ER because you need steroids and epinephrine and an IV and that kind of treatment, and then come back and you can come right back onto hospice. Or someone might change their mind and say, I would rather actually get this pneumonia treated with IV antibiotics and get home because this time I'm having on hospice, I want to extend it. I'm having good quality of life. And that's okay. It's okay to sign off of hospice and then come back on. We don't want, that's not the goal, but that happens and there's no sort of penalty for that.
Yeah, and sometimes patients feel like they may want to change their mind, or if a lot of times once they go on hospice, actually they feel better than when they're on treatments with us. I've had that happen several times actually. So the patients tell me, well, I actually feel pretty good, even though I told you I want to stop treatment. So can we at least see where my tumor is? Maybe I want to go back on treatment. So they can sign off hospice, and then we can get MRIs and consider active treatments again. So, but oftentimes I have to say patients then realize, they're happy actually being off treatments. That's why they're doing better, oftentimes. But patients can sign on and off hospice, even while on hospice. Can Nevada residents donate their body to UCLA? So most of the time, things like organs or even brain tumors for research are really need fresh tissues. So it's probably, we probably wouldn't be able to take donations from more than, like an hour, 2 hours away from UCLA.
David asked, what does treatment mean for me to qualify for hospice? Like if I'm still eating, is that treatment that would preclude me from being hospice eligible? And it is not. That's not a problem to be hospice eligible. So hospice eligible, we mentioned, we think around 6 months or less, but we're not great at predicting that. And there's a lot of variability. So some people are on hospice for years. And as long as a physician can say, I think they may have 6 months or less, then they are hospice eligible, but certainly they can still be eating and have like a fairly good quality of life.
Yeah, so it's really mostly referred to things like radiation and chemotherapies. But otherwise kind of the day-to-day life needs, those can still continue as normal. And we should also, we do continue our seizure medications. We continue some steroids. I mentioned earlier, I don't, think we should go very high on dosages, but we do continue some steroids. So those are actually usually continued for patients. I think, do I talk about EOLOA or do I wait for patients to ask? I have to say I tend to wait. I don't know, Dr. Siegel.
Yeah, it's sort of written that you're not supposed to bring it up, and this is something that a patient has to request and bring up. And of course, that raises some ethical questions too, of who has access to that information and would find out on their own, and who wouldn't, but would really want to utilize that. But in general, we wait for the patient to ask.
Yeah, unfortunately, that's also part of the law that's written in too. So we usually don't say here's an option. So I'm not sure if there's any additional questions at this point. I do want to let you know that if you see a chat button, the link to the survey is there. So do add that in for us. And then somebody asked in the past, they said he could mention it once. Yeah, I mean, in general, I think I would say bringing up ELOA is like if patients ask me, like they don't necessarily say, I want to ask about End of Life Option Act. They just say, is there such a thing, or what else do I do other than hospice? And maybe, I'll say, well, there's a law, but without the patient having some prompting, we're not allowed to say, hey, here, this is something you can do. So I think we're at 5:30. So I really appreciate all of you who come on and listen to our webinar. We'll record it, and I think for all of the people who did register, we'll be able to send out an email to let them know where to watch the recording once we have it uploaded online. It'll probably be just for a short time. So if you have any friends or family that want to watch it later, also you can send them the link. That's fine with us. And other than that, we'll hope to have more webinars, and as well as our usual neuro-oncology patient care conference. We'll probably have one again toward the spring of next year in 2024, where we're in person. And then you'll probably see me and Dr. Siegel again at that time. So thank you, everybody.
Thank you all so much.